The question, I think, is how does mental health in JM kids relate to other rheumatic chronic diseases that we know more about, and how could we learn from them and help us in JM? Is that kind of it? Okay, who would like to take that one
on? So I think that, we probably have the most information for kids with lupus with regard to the effects on mental health. And that's mainly because the inflammation in lupus it's known to directly affect the brain. So depression and anxiety and even things like psychosis or hallucinations are known to occur in some of our kids with lupus. So there's been a lot of studies that have looked at, well, why is that happening? And so in one of my slides, I had mentioned that there's a growing appreciation of the relationship between inflammation and brain health, and that's sort of getting at that. So I think that very well may be applicable to juvenile myositis. However, it's not been studied. But we are thinking about how to apply some of that knowledge and thinking about looking at that in juvenile myositis. But I think that as far as other things go in terms of the psychological burden of managing a chronic illness, as well as the medication side effects that can occur that can affect well-being, such as steroid side effects or having to have injections on a regular basis. These are all things that we've seen in other populations, such as lupus and such as juvenile arthritis. So I do think absolutely the knowledge that we've learned from other rheumatic populations is applicable, but I think we also have to be careful not to sort of do a blanket transfer of that knowledge. We really need to recognize and look further into what are the specifics for juvenile myositis so that we're not carelessly doing things that may or may not be helpful.
Just want to add like one or two thoughts as well. So, and correct me if I'm wrong, guys, but like, so I think in general, like ballpark estimates of, depression, anxiety, major psychiatric illness in kids kind of ranges like 10 to 20%. And then when you get into chronic illness populations, you start getting up into like 20 or 30% average ranges. And so you can see like Dr. Knight's data, we're there or higher in JM. And I think that's true in lupus as well. So I would say, there's a lot of distress across rheumatic disease populations, but I think like JM and lupus, because those are pretty intense conditions to live with and intense conditions to treat, I think they actually probably stand out at least somewhat from even some of the other rheumatic conditions. The other thing that I was thinking about is as far as like contextual factors that might be unique to JM, the ones that come to my mind, one is like the younger age at onset. Most of the rheumatic diseases in kids like kind of hit more, like a little bit more into adolescence or pre-adolescence. And JM is a condition where that can happen, but a lot of the kids will be elementary school or even preschool age. And so the meaning of chronic illness is different. The other thing is the treatments for each disease in rheumatology are similar but also different. There's a lot of steroid use in juvenile myositis, and unfortunately there has to be. And steroids, we know, have a huge effect on the emotional well-being of kids and their families. So they're the double-edged sword. And kids with juvenile myositis often have to be on steroids for really prolonged periods of time. So it's not just like a short-term stressor. It's this like year to 2 year long intense journey. And then methotrexate, I think, is underrated in terms of the amount of, underrated by us, I should say, in terms of the amount of distress it can provoke. Because it's more than just a shot. Everyone dislikes getting a shot, and needle phobia is quite common in children across, again, healthcare populations. But the anticipatory nausea that's very common, in studies, like up to 50% of kids on injectable methotrexate will develop this anticipatory nausea where just seeing the yellow color or smelling the alcohol swab or seeing the needle or knowing it's your shot day, any one or all of those can provoke tremendous anxiety and actual bodily responses like nausea and vomiting. That's a really intense part of living with JM that I think like we need to do a better job of understanding, like why is it happening and how can we deal with it. So, yeah. I had a medical student get interested in that, and she did a little study in our clinic, and unfortunately, like, the data didn't show us like why it's happening. So I'm still like totally, I know it's happening, but I still feel very ignorant about it. So any ideas are welcome for another study we can try out. Yes. Sorry? Yes, yeah. Thanks for saying that. A comment in the front is that this happens with the oral methotrexate as well. And I not universally, I will say. Some kids tolerate one or the other better, but many kids struggle with both. So, and that's important because we're often taught in our kind of schooling that, you know, one form or the other is less prone to provoking nausea. I don't know. My grandma's on methotrexate. It's not an easy medicine to be on. So.
Having anxiety or depression makes you more sensitive to body sensations. So you pay more attention to whatever's going on in your body. And so that can kind of magnify the symptoms as well.
If you have a child who's resistant to therapy or CBT or any other therapy, does that create more anxiety? And how do you deal with helping them get the support and help that they need?
That's a great question. So if you had a different disorder and there was a needed treatment, and the child was resistant to that, like cancer, we wouldn't kind of avoid that. And so anxiety can be pretty debilitating if it starts in childhood and it's severe and it gets worse. So it's really important to get treatment. If the child does not want to go, a lot of times what we do is provide, so for example, they don't have the internal motivation to help themselves with the anxiety because anxiety is scary. And so why would you want to put yourself through therapy that makes you anxious? So that's understandable. We provide external motivation. So the therapist will work with the parents oftentimes first to come up with a reward structure, a reward-based behavioral modification program such that they go to therapy and they get to go out to a movie with mom, or you provide that external motivation first until there's the internal motivation. And thinking about what are some of the factors contributing to the resistance? Is it because they're socially anxious and they don't want to go in the car and go to the clinic, or they don't want to talk to a stranger? What are some of those barriers, and helping to kind of work through that? So sometimes it involves just meeting with the parents, the therapist meeting with the parents first to help the parents support the child in being able to go and tolerate the therapy.
But I'm going to ask one quick question because I don't think it gets addressed enough, and that is we have measures, CBT therapy for kids, but what if they're not at that level of cognition? What if they're 3 years old and 4 years old and 5 years old? What kinds of other therapy options are there?
So you can do CBT down to about 5 or 6, depending on cognitive level of the kid. And there's manualized approaches such as Coping Cat, and it focuses on emotion identification and regulation skills. And so the kid will learn, like, if they're feeling, oftentimes they use a stoplight analogy, like green is good and yellow is kind of on the edge, and then red, you're in a bad place. And so a lot of times anxiety and depression in those little kids will manifest as those behavioral symptoms that I was talking about. So acting out or having tantrums or behavioral dysregulation. And so a lot of that work is done with the parents. So it's parent training to help you as caregivers respond in a way that limits the kid having those episodes. So kind of ignoring non-dangerous behaviors, a lot of positive reinforcement for pro-social behaviors. So it's a lot of focus on the parent. And then there's also something called parent-child interaction therapy, which is where, and that's kind of a specialized therapy that only exists in certain areas, but the parent puts a little bug in their ear, and then the therapist will talk to the parent interacting with the child and kind of guide them in what to do with the child. And that's for pretty young kids as well.
So the question is, are we going to be doing some longitudinal studies to look at how the traumatic experience of having a chronic illness and its interventions affects people as they're growing and as they become adults? Yeah. Okay.
So we would love to do that. Is the first answer. To some extent, it depends on having the mechanism to do so. So in terms of things that allow us to do that are things like registries, for example, that allows us to track patients and how they're doing over periods of time. So one such registry is like the Kaveh registry, which is putting a lot more recent effort into having JM patients as part of that registry. Now, I will say that in terms of capturing sort of psychosocial measures, we're not quite there yet. We are pushing for it, and there are efforts and ideas and project ideas to really get those incorporated. So we're working on that. But I do think it's important. And, we've looked at this in using other sources for things like lupus, and it's there. We do see that, we did a study comparing childhood onset lupus to adult onset lupus and depression in those two groups. And the patients, now adults, all adults, with childhood onset lupus had higher rates of depression. So we absolutely would love to do those studies for juvenile myositis.
Yeah, and it's actually interesting that you mentioned that idea of like looking at the trajectory of things over time, because that's like really how I started to get interested in emotional health as a topic per se, because really thinking about how this isn't just a condition you have it once and then it's gone. This is a whole life-changing event, and even when it's in remission, it's not really gone, right? And so that number one was what stood out to me as I learned about families' experiences, and two, I've been really moved by seeing how different every family's experience is, and some kind of almost in this like mind-blowing way seem to just take this event and just like keep on trucking in a way. And I'm like, that is like unbelievable. And I'm wondering, how can that be? And then of course there are others where there's a lot of distress and life turns way upside down, and it sometimes comes back to normal, or sometimes it stays upside down for a long time. And it's puzzled me, like, so what are the differences, and what are we not doing to help people, get their feet back on the ground and make meaning of all this? And there's actually, there is research that's being done writ large on this kind of topic. Like there's the researcher named George Bonanno out of New York, I think at Columbia, who does like work on, this is more in adults who have like spousal loss, and then looking at like the long-term trajectory of mental health for the surviving spouse. And he uses a technique called latent trajectory analysis, where you actually gather data on, depression or anxiety or anything you want to look at, and you gather it over time, and you can look at not just where someone starts and where they end up however many years later, but the path they take. Do they experience a ton of distress and then cope quickly? Do they experience a little distress at first, but then it smolders and gets worse? And you can actually find that there are a couple of major paths that people take. You can kind of start lumping those folks into these paths and then thinking, all right, well, what makes this group of people unique compared to these folks, and how can we respond flexibly to those different experiences and bring those paths back to wellness?
I think it also speaks to strength and resilience, and there's so much that we have to learn about resilience and what factors promote resilience and strength in these populations, and not just focusing on the risk, but what are those factors that promote resilience as well.